So thank you for that, Shannon. What we're going to do now is I'm going to just do a quick run through of a bit of a program update for what we're doing here at NDARC, and then I'm going to invite our panellists to the stage. So if I could please have the slides on and have the screen back, that would be great, kind IT people. So I'm going to just take a minute to introduce you to some of the work we're doing here as part of the RISE team at NDARC. So the RISE team aims to embed evidence and research into practice, community and health settings. Oh yay, my slides are up, great. Okay, so just really quickly, prevention, we know it reduces personal, family and community harms. We know it's a priority of governments, it's part of the National Drug Strategy. We also know that it saves money. For every dollar spent, research has shown that it saves about $14 return on investment. There are plenty of examples about early intervention working. For example, screening and brief interventions done in health services can reduce the number of people drinking at risky levels. Also, treatment is expensive, right? So if we can reduce the number of people going into treatment or the severity of their addiction or the severity of their drinking, then we can save money for the health system. So at NDARC, we've started a new program called Sustain. Do you like our logo? It's new. We think it's pretty cool. So Sustain is focused on rural and regional, New South Wales in particular, around prevention and early intervention. We've worked with some graphic designers here to design this logo, including John Evans and Bronwyn Smith, who's a beautiful Aboriginal artist, to incorporate some Aboriginal elements into this as well. Who is the Sustain team? We have a small but mighty team. I'd like to introduce Dr. Catherine Foley, Dr. Alison Seccull, Dr. Peter Gates, Dr. Andrea Zirko, and of course, under the leadership of Professor Michael Farrell. So just really quickly, what we're trying to do with Sustain is focused around 4 key principles. What we're trying to do, oh no, my slides have gone wonky. Oh dear. Okay, you're gonna have to just listen then and not read. The first one is around the uptake of evidence. And so this is about using evidence that we know, that shows about things we know works and trying to get it taken up into practice. We're not trying to create new things, we're trying to go with what we know works. Next, we're interested in identifying and co-designing with end users strategies that are fit for purpose for that environment. We're interested in building sustainability. So this is about not building research infrastructure that's separate to the real world. We want to build things into practice so that it doesn't all fall down the minute we leave. And finally, we're interested in identifying outcomes. So this is about acceptability, feasibility, effectiveness, how do we know what works, and also costs. So how can we show cost savings for this work? Lofty, I hear you saying, yes, it is a bit, but what we're trying to do is run through 4 co-design phases for each of our projects. Now this work is based off some of Kath Foley's work. I'll encourage you to focus on her paper down the bottom there if you want to see more information. But just really briefly, we go through 4 phases. The first is around securing participation and buy-in. The next is around problem identification. And then we focus on co-designing particular programs with communities. And so to do this, we use 3 different data sources. The first one is the research evidence. So systematic reviews, Cochrane reviews, what does the data say about what works? The next is this expert view thing. So this is where we work with and we talk to community members and clinicians about what they think. What's going to work in your setting? How can we best apply this evidence in your setting? And finally, we look at policies. So we bring all of this together through a process. It's an iterative process, back and forth. I'm glad the first presenter set this up really well, this process of really back and forth and trying to organise a model of care that is responsive to all of these different data sources. And finally, it's about implementation and evaluation. We have 3 program streams here. I'm not going to talk too much about them today, and I'm going to pause here and now welcome the wonderful Alison Seccull to stage, who's going to join us and give us a really quick case study of one of the programs that we're running out through Sustain currently. So please join me in welcoming Alison. Alison's a public health physician. She's based in rural New South Wales, and she's a researcher, and she wears too many hats for me to go through, so I'm just going to hand straight over to Alison. Thank you.
Hello everyone, it's so lovely to be here and so nice to meet you. I'm Alison, clinician from Coffs Harbour, Gumbaynggirr country, aka a humble healthcare worker from Hicksville. So I'm going to concentrate on the co-design element of what Sarah's been talking about and talk about a little project we've been doing in Coffs. And I want you to put down your mobile phones, close your laptops, because obviously this is going to be the most exciting, impactful and interesting talk that you're going to listen to today. I've got to push the button and change my slides. So here's my fantastic team of people who have an amazing range of skills, including fixing the IT this morning. Thank you, Gina. Thank you so much. And I just want to tell you something that you're not going to believe. I actually really loved doing this study despite my incessant whinging about research. So just leaving that with you guys. Okay, so what's the background here? I work in an opioid treatment program part-time in Coffs Harbour, and we have a big challenge. If you're not over OAT, we do have some real challenges in prescribing. We've got more patients than we can really manage, especially in rural and regional Australia. Lucky us in the country, we are fatter, older, poorer, undereducated and more likely to die earlier than people in the city, but hey, the parking is way better, guys. All right, so what are we going to do about this? We get lots of people coming into the clinic, but there's traditionally been a huge problem getting them out into primary care, and I'm sitting there as a non-specialist addiction physician thinking these people would be so much better looked after in primary care because they can attend to their screening and healthcare needs as well. What can we do about this? Well, hey, isn't ignorance bliss? It's actually a really hard nut to crack, but I've got a mildly hopeful story to tell you. All right, so we interviewed experts, and by that I mean clients, healthcare providers of lots of stripes, so nurses, both in practices and OTP programs, pharmacists who dispense in the community, and doctors and nurse practitioners who prescribe. We looked at the evidence, which is really good around we can manage stable clients in primary care really well. And then we put all that into our magic mix master and we blended it up and created a fantastic pilot service delivery model, which we've now trialled. Okay, so we're talking small numbers because one of the big issues in country areas is you sometimes will have one GP with a special interest, they've got 60 clients, all of a sudden they have a heart attack or retire, and then the clinic's got to absorb, 25% of their service, within a month. So we want to avoid that sort of boom or bust. Okay, so I'm really going to try and focus on rural and regional because you've heard a lot about, drinking workforces, so I will try and tailor it to what's important around rural and regional. I mentioned we're older, so are our GPs. So they're on average 5 years older, so they're cracking 50 and a third of them are going to retire in 10 years. And the problem is acute, and I know it's really acute in outer metropolitan as well, but in Coffs Harbour, which is the 26th biggest city in Australia and the only one with a giant banana, our bulk billing rates are appalling. So the only fully bulk billing practice in town is Galambilla, Aboriginal Medical Service. And, so many practices are now forced to bulk bill healthcare card holders and children under 16 because the business model just requires them to do that to stay afloat. We have, in fact, had 3 general practices close in my local area in the last 12 months. And the books are often closed, so it's super hard to get patients in. On average, you're waiting 2 to 8 weeks for a general practice appointment in Coffs, okay, worse in the outer regions. So options are pretty limited. And here is where it really gets difficult for people. Shannon mentioned, shame, stigma, and not being able to access services. So even in my pretty compact LHD, we do have, single providers in small towns, and that is really difficult for both providers and clients. So what people said to us was, I am really afraid if I tell my GP that I'm on OTP, they're going to get rid of me, or every health problem becomes about me being a drug addict, and I don't want to do that. And then we had GPs or pharmacists say, look, I care, I'm interested, but I'm really worried I'm going to become a magnet for every drug-seeking person within a 100-kilometre radius, so that's why I'm turning you down. So really important to be aware of. And the distance is a real issue. So I'll have clients come, they've driven down the Waterfall Way from Dorrigo, they're from further out, so Tyringham or Dundurban. They've driven 90 minutes to see me if they have a car. That road is often cut due to landslides if it rains. So that's a big day. If they work, they're giving up a full day of casual work in a population where, you know, money is a big issue. So it is really difficult for clients. Okay, but here's the mildly hopeful part. I have heard from many people, GPs are really hard to get involved in OAT. They just don't want to do it. We've tried so many things. We're sort of throwing our hands up in the air and giving up. So one of the great things about rural and regional GPs are, they'll give it a lash. So I found more often than I expected that it wasn't a lack of will, it was just a lack of knowledge. So things like nearly every GP I spoke to wasn't aware that they didn't need to be accredited to prescribe OAT in small numbers. The level of knowledge can be, what is buprenorphine? Sorry about that, that's not great, but anyway. So what did we find? We found if we were able to help them and be really responsive to what they were asking us, then they were willing to give things a go. And the other difference that we made was we were looking at a number of GPs in small numbers taking their own patients rather than trying to get someone to prescribe for 20 or 40 or 60 patients. So what really helped was we went for the low-hanging fruit first, and the idea being if the client is known to them, we approach the GP and say, hey, how would you feel about that? Generally, there's a few stipulations that they're really interested in. The number one thing was they need the golden ticket. I need a no questions asked return policy for this patient if anything whatsoever goes wrong. Sure, we're happy with that. And then we talked about some help with transfer. So there's lots of little friction points that when you're working really hard, it's just enough for you to throw up your hands and go, too hard, I'm not doing it. So we worked really hard on those. So what my take-home messages for you is there's definitely no one-size-fits-all model, but there are some cool components that are really, really helpful. We talked about that golden ticket, we talked about help. So for us in our LHD, we found a customer service approach was really, really key. We acted like concierges, and my wonderful, wonderful Jill Raby was the person that made that magic happen by talking and listening to GPs and clients. So she did things like the pharmacist didn't know how to use the special ordering system for Buvidal, and she got that sorted, and that stopped one patient falling off. She was able to fill out the PRU applications for people. She was able to answer nervous clients' questions about what if, or oh my gosh, my practice has given me an appointment for 3 weeks and 4 days and I need my injection in 3 weeks and 0 days. She was able to go out and help practice nurses learn how to inject Buvidal. And answer a myriad of questions. So that really, really helped for us, and really listening to each individual client and practitioner about what they needed to make it work. So if you focus on relationships and really think about customer service for both clients and practitioners, we found that helpful. We hit our target, and none of our patients have come back yet. So they're out enjoying life in primary care, which we're really, really super happy about. Thanks for listening.
Okay, so that's it from us. I'm going to now ask our fantastic panellists to join us, and if we could please have Shanna back on screen, if that's possible. So I'd like to introduce the wonderful Jess Duminy to come up on stage with us. Jess is the research lead at the Australian Injecting and Illicit Drug Users League. You can see how I tripped up those words, right? She has 15 years plus experience working with Aboriginal community-controlled health services across health and social services. Welcome, Jess. We've also got Dr. Michael Doyle, who will join us. Michael is a Senior Research Fellow at the University of Sydney, Centre of Research Excellence for Indigenous Health and Alcohol at the Central Clinical School. And the wonderful Dr. Suzie Hudson, who is coming up as well, who's the current Clinical Director at New South Wales Health Centre for Alcohol and Other Drug. Suzie has loads of hats and loads of experience. She's a social worker and was the Clinical Director for many years at NADA, the Network for Alcohol and Other Drug Agencies. Okay, so this is the fun part. Time for questions. I had a couple questions planned. They are pre-mic'd. Yeah, so if we could turn the mics on, that would be fantastic. And I'm going to hand over to you. Where should we start? Who's got the first question to kick us off? I've got loads of questions, so I'm going to jump in. I'm going to start, if I can, with Michael. Sorry to put you on the spot, Michael. I was wondering your reflections on listening to Alison talk and Shanna talk. If you had any thoughts about what we can be doing and what works really well in the populations that you work with. So this is with people in the prison system and with Aboriginal and Torres Strait Islander people in particular. If you had any reflections.
Thanks, Sarah. I couldn't help, but the similarities struck me about the story in the video we watched, and about growing up in such a way that alcohol was always present, and it's just the social lubricant in a regional area. And that's very much a very similar story for Aboriginal people in regional areas as well. So we've got, there certainly is a lot more work to be done around that. But I also, reflecting on recent events, we have this divide in Australia. And we really do need to, when we're thinking about all these things, we have to have a sort of an integrated approach. And that's what I love about the research I'm doing with Alison and Kath, is that we're kind of doing it all together. And we have similar challenges that we're looking at, say with access in regional areas, but there are slightly different takes on it for the Aboriginal community. I think in terms of access to OTP, it's getting to if you collectively, your family is not in the best, you have a lower socioeconomic status, some of those challenges of getting transport and those things are even more difficult. And then you kind of end up becoming tethered to having to live in the major regional centres, or in Sydney or Newcastle, or the major cities as well. And so if we're able to offer better treatment in regional areas, then people can kind of have better, they can live at home where they kind of want to be in a lot of cases as well, or have greater flexibility. I guess I'm not sure if I'm quite answering your question, but I thought that was a few reflections on the presentations.
Okay, I'm back. I thought I might roam. Thanks, Michael. That's great. Really lovely. Thank you. Any questions? I can't see anyone. Put hands up. Oh, we've got one. Okay, I was going to think of something. Here we go. Thank you.
Hi. This one's kind of directed to sober in the country. So I'm just wondering if you guys kind of connected with Alcoholics Anonymous, if you've used any of their resources or any of their models. If not, why? That sounded so accusatory, but just just more interested.
Have I connected with who, sorry?
It's about Alcoholics Anonymous, sorry, if you've connected with Alcoholics Anonymous with any of your work, Shanna.
Oh, no, that's a great question. No, there's no accusation. Yeah, so we are connected with all possible resources, from Indigenous helplines to AA. We recommend every single one of them through our website. We have absolutely nothing but open hearts to all other avenues, and we literally, our modus operandi is to link people that come to us with whatever support services are on offer out there. Interestingly enough, here's some trivia for you guys. So I actually started my sober journey with AA because it's all I'd ever heard of. And I stepped back and left the fellowship because they're very strict about nobody speaking in public, radio, to the press, etc. And I wanted to honour that. So I stopped being an AA member. But to this day, I will always say to people, give it a try if you haven't given it a try. The major issue is we can't often have anonymity, and there are very rarely meetings or services on offer for rural people. There's just no meetings for so many of the people who come to us. And in fact, the entire reason I started the conversation is because I was one such person who couldn't get to meetings. It was a model that didn't work for me because I couldn't be anonymous and I couldn't get to a meeting. It was really difficult. And interestingly, here's another bit of really interesting trivia. AA were actually very fiercely critical when they found out what I was doing. And they said, you can't do it like this. It must be face-to-face and it must be like this and so forth. And I was very friendly in my response. And I said, I totally understand that that's an awesome thing if you can get it, but we can't. So what do we do and where do we go? And that criticism was actually quite fierce from that corner of the world in the early days. And then when COVID-19 hit Australia, within a week or two, nearly every single face-to-face recovery meeting of any kind in the globe shifted online. And every critic I ever had vanished and dried up. And in fact, a lot of apologies started coming through, and people said, my God, Shanna, I'm so sorry. I was one of the people who attacked you and your organisation, and now I understand your life is ISO. I didn't get it. So it's really weird. COVID kind of demonstrated to the globe what it's like when you live in permanent isolation. But yeah, if you go to the resources section of our website, we recommend everyone have a look at all of the things on offer, including AA. I have a lot of great things to say about the organisation. Yeah.
Perfect. Thanks, Shanna. You've picked up an interesting point about the anonymity and people being reluctant to go to meetings because they know people who are there and it's a small community. And it made me think about a conversation I had earlier this week with Jess about some of your work. I wondered if you had any reflections on confidentiality and anonymity in small communities.
Yeah, I suppose in the context in which I sort of explored it in my work, I was looking at antecedents and barriers to implement a family-centred model up in the Cape York community based on Apuna family-centred approach to comprehensive primary healthcare. If I sort of parallel that with learnings as sort of appear on the methadone program, like I suppose in those situations and sort of what we found with it was a sort of double-edged sword. Yes, there's that familiarity, but as an Aboriginal health worker-led model, that knowing and familiarity was also intrinsic to accessing the households, with a model that hinged on home visits, knowing, what household had dogs, even just the practicalities, but also it's more so about, I guess, the policies and procedures that you put around those health workers to ensure sort of safe practice and making sure that, just because that's a visible person to the community, that they don't receive all the emergency contact, especially when there's fears of engaging with police, ambulance, and that's also another issue. Northern Rivers, and about an hour and a half access to sort of any sort of health sort of service. But I think an important point, I think nothing's prescriptive. There are cross-pollinating learnings to be sort of acquired from across all different areas and responses. And at the end of the day, though, I think it's the people that you're providing to have the answers, and it's important to come back to them. Just because something might be a risk, there's always a strategy to sort of respond and mitigate. Doesn't mean that it's not worthwhile, you know what I mean? And at the end of the day, peers and those who have the lived experience of others, they've got the answers to this, their own solutions, because it's very different from, there's a power play constantly, with the
Beautifully said. Yeah, thank you. That's great. I've got another question, but I'll hold off in case there's other questions people wanting to ask. There's one up the back there. Thanks, Tori.
Hello, my name's Claire. My question's for Alison. I was wondering, you talked about your model, hello, now you can see me, picking the low-hanging fruit of the people who are already in a primary health network. What did you see coming out from after that? Was the experience of the clinicians that they were then going for that higher fruit? Do you think that, you know, that this will lead to them taking on patients that were new to them, for example?
So, yeah, that's the hope. So what we didn't want to do is overwhelm prescribers. We said, look, we'll give you one, maybe two, and then you have maybe one prescriber in a practice, and then the registrar sees that that person is prescribing. Okay, it's not as hard as I thought. GPs do this. We now have two prescribers in one practice. So when prescriber X goes on holiday, prescriber Y can be their locum. And that's another thing that we do for them. If they go on holiday and forget, we can, in an emergency, provide that extension of script because it's very bureaucratic. So the idea is that groundswell, that it just becomes another chronic disease that we can manage in primary care. And that thought that opioid use disorder, you have stable clients who are well, who can be looked after in primary care, but if they're unstable or unwell, then there is a specialist provider that I can refer to and have them come back to me. So that's what I'd love to see happen, but it's going to take some time. There's a couple of things that irk me about medical student education, one of which is very underdone in the alcohol, other drugs department. So they come out not really knowing a lot and being frightened of it. And I don't know, that's another stigma, isn't it? Because it's a massive problem that primary care people are dealing with every single day. I don't know, statistically speaking, probably 5 out of the 30 people they see will have some kind of alcohol or other drug disorder. So just the normalisation over time. Very long answer to a very simple question.
Thanks, Alison. Suzie, I wanted to invite your reflections, if you had any thoughts. In particular, it strikes me listening to Shanna and Alison talk about, these things, they seem to be working.
Yeah.
How do we get support for them? What sorts of evidence do we need to be generating to get these more widespread and taken up more broadly? And also whatever else you'd like to talk about.
Well, thanks, Sarah. I think what comes through really clearly, and I think what we're trying to do and what we're seeing more and more of, is listening better to what communities are saying they need, trusting that they have the answers to that, and then supporting that. And I think things like, obviously, we had not that long ago, and it did take a while to get some traction and some action, but things like the Special Commission and other opportunities where we actually go out into communities, we hear, particularly in rural and regional areas, what the sticking points are. We can then start to build better responses and better policy. I think the other thing that we've seen a huge increase in, but we need to invest more in, and I think we're trying to do that particularly at the Centre for AOD, is to really build and grow and support the consumer voice, and having people at the table to do things like, be on interview panels, to be on tender panels for new services. Certainly the other thing that and I suppose it's also, hiring people like me who are still seeing clients in the community, have a voice about how we should shape the way we fund prevention and treatment is key. And I think we've learned a lot, and we've still got a lot to learn, particularly from our Aboriginal communities and colleagues. We haven't always done very well in that space, and I think we acknowledge that. And what we've tried to do is be a lot more flexible. So that is, you try something, it's not working, you hear what people have to say about that, and you bring them closer to the positions of power, closer to the decision making and the shaping, not only of policy, but how we fund things. And I think that's what's happening now. Certainly we need to do more. But what I'm hearing and what I've heard today from Shanna and others is the answers are there often in the community. We just need to do better at listening to that. But also that we are really cognizant of having the variety of services out there, that it's not a one size fits all, and that means, you know, we need as many options as is possible. We need to bring services to where the people are at, and also, I suppose too, recognise that for others, being in their community is, moving away from their community is sometimes what they need too. So what that tells us is that we continue to support, invest in a range of options, but that we also spend a bit more time thinking about that prevention side of things.
Beautiful. Thanks, Suzie. Yeah, Michael, go ahead.
I think we should give credit where credit is due, and New South Wales Health has really made a monumental shift, and I do want to acknowledge that, and that's something that's been noticed within the Aboriginal community and drug and alcohol workforce, so well done. There's always more to be done, but we're in a pretty good space now, I think.
Great, thanks, Michael. We've probably got a moment more for one more question. I can see a couple of hands up the back, so maybe if we could get a mic through there, thank you. I'm not going to get through all my questions. How disappointing. That's okay.
Thanks very much, panel, for wonderful insights. I'm Danielle from NDARC, and thanks very much, Alison, for a very fascinating talk about the rural services regarding to OTP program. And I guess for pregnant women and those with very, very small children, getting to services will be more difficult for them. So I would like to just want you to share some information about the availability of services for pregnant women in your area.
Is that for Alison?
Yes.
Yep, sure. So I think the question, Alison, was around services for pregnant women around drug and alcohol in your area, if you know of any.
Yeah. So we have a SUPS nurse, substance use in pregnancy, who's fantastic and does an amazing job. Yeah, so really great services, and you know, women are often highly motivated in pregnancy, so it's a great point in their life in which to be able to provide intervention. Yeah.
And just on that, there's been, I suppose, an injection of additional funds to support those services because we know that they work, but it's also about recognising the stigma that women experience. And another piece of work that's really important is around working with all of our health colleagues who may come across people who could become pregnant or are pregnant, and being able to really engage them in a non-stigmatising way if indeed they are experiencing concerns around alcohol and other drug use. And I think, you know, we've still got a lot to do in that stigma space, particularly for women. But I think, you know, the services that we've seen work are where we bring together that AOD experience, working alongside other health professionals to try to break that down.
As someone who's on the methadone program while pregnant, like, there's nothing in the Northern Rivers. There used to be a program, but it wasn't until like I was a month out from due and I was badgering the hospital to get some information on what the hell to expect. Like, yeah, it was really bad.
Yeah, well, hopefully that's
important to hear too.
Yeah.
That what is it? Where are those gaps, and what can we do?
And in the hospital themselves, the amount like midwives that had no experience with someone on methadone was yeah. And that's also part of like the rise of vice and that. But yeah, there's a lot of issues. Yeah,
and if you it's that idea too that you're trying to advocate for yourself and your family and your child. I can only appreciate how challenging that can be.
Yeah, I mean, it really shows, you know, the importance of this stuff, like what Kat's been doing with the co-design and others around really bringing together all of this, kind of the expert view, the policy stuff, like what you've got, the research, and also the lived experience of people so that we can create things that really have impact. Okay, I'm pretty passionate about getting people out on time for lunch. It's 12:30, so I really want to thank our panellists for joining us today, in particular Jess, who's brought along her young son Will, who's hovering around. So thank you so much for coming. We really appreciate your time. So please join me in thanking our panellists today.